Hello friends, today we are going to discuss about antiphospholipid syndrome. The antiphospholipid syndrome is the systemic autoimmune disease defined by thrombotic and the obstetrical event that occurs in patients with the persistent antiphospholipid antibodies. The thrombotic antiphospholipid syndrome is characterized by the venous, arterial and the microvascular thrombosis. And the patient with the catastrophic antiphospholipid syndrome present with the thrombosis involving multiple organs. Obstetrical antiphospholipid syndrome is characterized by the fetal loss after 10th week of gestation, recurrent early miscarriage, intrauterine growth restriction, or severe preeclampsia. Antiphospholipid syndrome can occur alone or in presence of other autoimmune disease. Association with the systemic lupus erythematosus is the most frequent, but other diseases such as rheumatoid arthritis, Sjogren's syndrome, and the inflammatory myopathies may also occur. About 30 to 40% of patients with the SLE present with the circulating antiphospholipid antibodies, and 15% will have the complete syndrome. Now about pathogenesis, antiphospholipid syndrome, that antiphospholipid antibodies like lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1 are classificatory antibodies of this disease used for the diagnosis, but also important element in the pathogenesis of antiphospholipid syndrome. Although the presence of this antibody is a predisposing factor for thrombotic event, a second trigger such as infection, prolonged rest, or inflammatory state is usually necessary for the progression of the syndrome. Now, these antiphospholipid antibodies bind to the phospholipids and plasma or membrane protein expressed in the various cells like platelet, endothelial cell, monocyte, fibroblast, and trophoblast, which produces the prothrombotic state. Beta-2 glycoprotein 1 and the prothrombin appear to be the major binding protein in these antibodies involved in the pathogenesis of the disease. There is also genetic component related to the HLA class 2 system that needs to be better studied and which may predispose the individual to the disease. Now we'll see the clinical aspect. Virtually all clinical manifestation of antiphospholipid syndrome are due to arterial and the venous thrombotic event. Theoretically, antiphospholipid syndrome thrombosis can occur in any organ, affecting vessels of different calibers and determining the greater number of clinical manifestations. It is also believed that placental insufficiency, the main reason for late fetal loss, is also related to the loss of uteroplacental circulation derived from thrombotic phenomena. Now we'll see the various thrombotic events that can be possible in antiphospholipid syndrome. Like in extremities, if there is a venous manifestation, then it can present as deep venous thrombosis. Arterial thrombosis can present as ischemia and gangrene. In liver, the venous thrombosis will produce the Budd-Chiari syndrome, and arterial thrombosis will produce liver infarction, nodular regenerative hyperplasia. In central nervous system, the venous thrombosis will manifest as sagittal sinus thrombosis, and if it in case of artery, it will produce the cerebrovascular accident. In lungs, if veins are involved, then it will produce the symptoms like pulmonary embolism and pulmonary hypertension. In kidney, vein thrombosis will produce renal vein thrombosis, and artery involvement will produce the renal artery thrombosis and thrombotic microangiopathy. In skin, if veins are involved, then that will produce the ulcers. In case of artery, it will produce the reticularis gangrene ulcers. In eyes, if veins are involved, then that will cause retinal vein thrombosis. If arteries are involved, then it is manifested as a retinal artery thrombosis. Now we'll see the obstetric events. Another frequent manifestation in women with antiphospholipid syndrome is the recurrent fetal loss, which may occur at any stage of pregnancy, but typically happens as of the second trimester. In addition to the fetal loss, placental insufficiency with the restricted fetal growth, preeclampsia, eclampsia, and preterm birth may occur. Only 10 to 15% of the women with the recurrent fetal loss are antiphospholipid positive, and the probability of finding antiphospholipid in the prenatal examination is less than 2%. That is why it is not a routine screening examination. Now, the non-criteria manifestation. There are other less frequent clinical manifestation, but also related to the antiphospholipid syndrome, but they are not part of the classification criteria of the disease. So the patient can manifest as migraine, convulsions, superficial venous thrombosis, ulcers, thrombocytopenia, chorea, sometimes longitudinal myelitis, renal microangiopathy, cardiac valvulopathies, libido reticularis. These are all non-criteria manifestations. Now we'll see what is the catastrophic antiphospholipid syndrome. This catastrophic antiphospholipid syndrome is characterized by the multiple thrombosis in short time period, that is 1 week. Although rare, this is most severe spectrum of antiphospholipid syndrome with mortality rate up to 50%. Now the diagnostic criteria, the classification criteria for antiphospholipid syndrome were developed in 1909 in Sapporo and subsequently revised in 2006 at International Congress held at Sydney. At present, they comprise the requirement of at least one clinical criteria, that is, any thrombotic event or gestational morbidity, or at least one lab criteria, that is, confirmed positive antiphospholipid antibody at two or more separate time points with 12 minimum week, with the 12 week of minimum interval should be there. So this is the diagrammatic representation of the diagnostic criteria of the antiphospholipid syndrome, which involve thrombotic event. So it includes thrombosis of any vessel, like arterial, any vessel like arterial involvement, venous involvement, or any small vessel involvement, confirmed by imaging or histopathology, and gestational morbidity, which include three or more losses in less than 10 weeks of gestation, or one or more loss in more than 10 weeks of gestation, preterm birth of less than 34 weeks due to eclampsia, preeclampsia, and placental insufficiency. And any of the the lab criteria includes the for the and the lab criteria includes the presence of antiphospholipid antibody, that is any of the antibody should be positive, which include anti-cardiolipin antibody, lupus anticoagulant, and anti-beta 2 glycoprotein antibody should be positive in 2 and 12 week of interval. Now lab aspects, the diagnosis of antiphospholipid antibody as proposed by Sydney criteria include the lab dosage of anticardiolipin, anti-beta 2 glycoprotein, and lupus antibody. So the two positive antibody measurements separated by the interval of 12 weeks should be obtained to rule out the possibility of transient positivity of antiphospholipid antibody induced by infection or drugs. Now we'll see one by one this what is this antiphospholipid antibodies. So first one is lupus anticoagulant. So lupus anticoagulant is the most specific test for the diagnosis of antiphospholipid syndrome and should be performed according to the International Society for Thrombosis and Homeostasis. And the next is anticardiolipin. It is the most sensitive test for antiphospholipid syndrome diagnosis. It is performed by the standardized enzyme immunoassay technique containing the source of beta 2 glycoprotein. Internationally used positive control are used so that this test has less variability and meets the international standards. This test is not influenced by the warfarin and heparin. Now, anti-beta 2 glycoprotein, these anti-beta 2 glycoprotein antibodies are also used and detected using ELISA technique and have recently been included in the classification criteria. Now, the indication of antiphospholipid antibody test. So, any presence of DVT or PE in young people without risk factor. If there is a thrombosis in atypical sites or multiple thrombosis. If cardiovascular accident or TI in patient age less than 50 years. Any thrombosis in patient with SLE or other autoimmune disease. Recurrent abortions are associated with the obstetric complication or any unexplained thrombocytopenia. Presence of libido reticularis. Now we'll see what are the differential diagnoses. The main differential diagnosis of antiphospholipid syndrome are hereditary and acquired thrombophilia. In hereditary thrombophilia, positive family history helps and guides the request for the complementary test. In this group, the presence of Leiden factor 5 and deficiencies of C and S protein and antithrombin 3 as well as mutant prothrombin must be taken into account. In acquired thrombophilia, in addition to antiphospholipid syndrome, hyperhomocysteemia can cause venous and arterial events. Predisposing factor for thrombosis should be investigated, such as nephrotic syndrome, atrial fibrillation, puerperium, use of estrogen, paraneoplastic syndromes. Other rheumatological disease, such as systemic vasculitis and Behçet disease, should be considered in the list of differential diagnoses. Diseases that occur with thrombocytopenia should be ruled out, including autoimmune thrombocytopenic purpura, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, heparin-induced thrombocytopenia, and DIC. So regarding gestational loss, whenever possible, we should investigate anatomical and genetic changes in mother and malformations in the fetus, as well as serology for infectious disease like toxoplasma, rubella, syphilis, cytomegalovirus, herpes, and HIV. Maternal hormonal changes should be investigated in addition to the use of alcohol or drug which may cause recurrent fetal loss. Now we'll see the treatment part. The treatment of antiphospholipid syndrome mainly involve treatment of acute thrombotic event as well as prevention of new event, whether thrombotic or unfavorable gestational outcome. Now the treatment of acute thrombotic event, the treatment of acute thrombosis is usually based on full anticoagulation, either with unfractionated heparin or low molecular weight heparin such as enoxaparin. So after initiation of full parenteral anticoagulation, an oral anticoagulant may be associated. The most commonly used are vitamin K antagonists. For vitamin K dose control, we use prothrombin time or iron. In case of arterial event or venous rethrombosis, INR target should be elevated to range of 2.5 to 3.5. An alternative to increase INR target would be to keep the target between 2 and 3 and to associate 100 mg aspirin, but the risk of bleeding is higher. In case of ischemic cerebrovascular accident, patients should be evaluated by a neurologist to assess the need for thrombolysis and only secondary prophylaxis. So it is the neurological team that will determine the best time to start secondary prophylaxis based on the risk of events hemorrhagic transformation. Now, regarding secondary prophylaxis, after acute episode, long-term treatment with oral anticoagulant is the therapy of choice, and the recommended INR target for prophylaxis after venous thrombosis is between 2 and 3, and for arterial phenomenon between 2.5 to 3.5. Recent studies have found higher INR, that is between 3 and 4, added increased risk of bleeding. In addition to the anticoagulant therapy, hydroxychloroquine seems to reduce antiphospholipid titer and has beneficial antithrombotic role for patients with antiphospholipid syndrome. Therefore, it should be added in all patients with APS associated with SA. In the specific case of first episode of atherosclerotic ischemic CVA, in the low risk patient, treatment with aspirin 300 mg or double antiplatelet therapy may be attempted before anticoagulation is initiated. In case of thromboembolic ischemic CVA, the treatment of choice is anticoagulation. Now, about primary prophylaxis, there is no evidence to support primary prophylaxis of persistently positive antiphospholipid patient without thrombotic and gestational event. However, this patient should receive prophylactic heparin in situation of high thrombotic risk, such as immobilization, hospitalization, or any postoperative condition. This patient should also avoid situations that increase the risk of thrombosis, such as smoking and the use of estrogen. Lupus anticoagulant is the test with the high predictive value for thrombotic event and unfavorable gestational outcome, and its positivity should be considered when inducing prophylaxis. Now, the treatment of obstetric event. Patient with the exclusive obstetric antiphospholipid who are not pregnant should be treated with aspirin alone at a dose of 81 to 100 mg per day. During pregnancy, aspirin should be associated with the prophylactic heparin, that is either unfractionated or low molecular. It should be maintained for up to 6 weeks after the delivery. Patient with the previous thrombotic event should use aspirin 100 mg associated with the full dose of heparin, that is enoxa. We can use enoxaparin 1 mg per kg every 12 hours. Vitamin K antagonists are the teratogenic between 6 to 9 weeks of pregnancy when heparin is better therapeutic option. So if unfractionated heparin is to be used, the dose should be adjusted in relation to the baseline prothrombin time uh, in relation to the baseline partial thrombotic time to maintain the baseline rate of 1.2 to 1.5. In general, doses of unfractionated heparin increase during pregnancy progression, while the dose of low molecular weight heparin remains the same throughout the pregnancy. Heparin, vitamin K, and aspirin are safe concerning the breastfeeding. Now, the treatment of catastrophic antiphospholipid syndrome. Patient with the catastrophic antiphospholipid syndrome, in addition to anticoagulation with heparin, patient should receive immunosuppression with the corticosteroid in the form of prednisolone 1 mg per kg per day or pulses of methylprednisolone associated with plasmapheresis or intravenous immunotherapy. Therefore, they should receive triple therapy, anticoagulation, corticosteroid, plasmapheresis, and immunotherapy. Rituximab can be used in the refractory cases. Recent studies have also demonstrated the benefit from the use of anti-5 monoclonal antibody, that is eculizumab, in patients with catastrophic antiphospholipid syndrome, proving the importance of complement activation in cases of thrombotic microangiopathy. Thank you.